Pratik, I'll give a brief introduction, and then you can start your talk, and then try to be on time and take 30-35 minutes to complete it. So, good morning, everyone. Dr. Pratik Thakkar is from University of in Auckland, in New Zealand, where he completed his PhD as well, and is currently working there. And he is a basic neuroscientist working on the role of stroke in cardiac dysfunction. Um, so I will let Dr. Pratik to take over and start his talk.
Thank you so much, everyone, for being here. And before I start, I would like to thank you, or I would like to thank Professor Vemiganti, Professor Damse, Department of Neurosurgery, and University of Wisconsin for this opportunity to present my research. Right, so myself, Pratik, and I'm basically working as a postdoc at the moment in Department of Physiology and School of Medical and Health Science at University of Auckland in New Zealand. So I'm presenting today, the data basically come from my doctoral research, which was based on a cardiovascular response to ischemic stroke, a preclinical study. Right, so before I go further, I'm pleased to inform you that some of the experimental chapters have been published in a peer-reviewed high-impact journals such as Stroke and Hypertension, and few more to come at the moment and under the submission. So the second paper, which was hypertension, was awarded as a high impact factor in the first quarter of the USA in the Hypertension Journal. Now, I would like to start stroke statistics. So as we all know, the stroke affects millions of families around the world, and generally millions of them die and many remain with the permanent disability. Pre-existing hypertension is a bigger risk factor, which accounts more than 50% of the stroke patients. If you talk about New Zealand, it's the second largest killer in New Zealand, and around 9,000 adults generally affected or die every year because of stroke, and 10% of the death coming from that 9,000 adults generally accounts for less than 65 years of age. So what is stroke? What is the etiology of stroke? So there's generally two types of stroke. One is a hemorrhagic stroke and second is ischemic stroke. As we all know, the hemorrhagic stroke accounts for the 20% of total stroke. And how that happens, basically, generally, one of the cerebral artery ruptures and which can spread the blood into the brain tissue causes a hemorrhagic stroke. And the second is ischemic stroke, which accounts more than or around 80% of total stroke. And how the ischemic stroke happens, as you can see in the figure right hand side, where basically the thrombus or emboli, which blocks one of the cerebral artery, which stops the blood to reach to the another part of the brain or the part of the brain, causes ischemic stroke. But what we have seen from the literature, that 80% of the stroke patient produce the post-stroke hypertensive response, as you can see, where the blood pressure increase in the acute period of stroke remain for days to weeks. And what we think behind that dynamic response produce itself, that the brain put itself a priority to get the more oxygen and blood supply to the affected area, which is kind of a penumbra area where actually still the injury is reversible. Now, if we think about the clinically, the post-stroke hypertension created a lot of real-world burning questions, such as, does the post-stroke hypertension differ in the patient with the untreated versus treated hypertensive patients? Or does the post-stroke hypertension is aiming to add the more blood flow to the brain, as I stated earlier, which is trying to recover the brain out of this injury? And the third one is, should the post-stroke hypertension be treated? Because the post-stroke hypertension produce at least more than 30 to 40 millimeter mercury increase or significant increase to the pre-stroke baseline level and may produce a hemorrhagic transformation or secondary stroke. So it should be treated or not should be treated, this ongoing discussion. And if the stroke patient has undiagnosed hypertension, so imagine that scenario, the patient present the stroke at the hospitalization and the clinician doesn't know the true pre-stroke baseline level, blood pressure may be over-treated and it's really dangerous. So these are the burning questions that we raise, and we check in our literature. There's none of the study has addressing these particular burning questions. And what the American Stroke Guidelines and all other international guidelines suggest that the blood pressure, which produce the best outcome in terms of the acute stroke period, which is not particularly known. So that's why we raise these issues and we raise these questions, and we're trying to address these questions to improve the understanding behind the post-stroke hypertension. And what we found from the literature that there are certain hidden and unaddressed issues in the clinical studies which may account for more mortality, more negative outcome, or maybe failure of the clinical trials. So the first one is undiagnosed hypertension. So generally around 15% of the population do not know their blood pressure is high. And undiagnosed hypertension may be present more than 25% of the stroke patients, which never know. And technically when we cannot identify these patients at the time of hospitalization, and the patient may mistakenly treated below their actually true baseline level. And the second is the treated hypertension. So if the patient already on antihypertensive treatment before stroke, they are still have a higher risk to having a stroke in their future life. And how to control this blood pressure in these patients at the time of acute period of stroke is still not clear. Whether the same drug should be applied or should be given in the acute period of stroke, or maybe in a combination, or the drug can be given in that particular acute period of stroke, and then the pre-stroke drug can be given again or started again after a certain period of stroke. So this has been not clear, and we found these are the major issues that should be addressed, actually, particularly with the right approach. So we made a black and white thesis aim as post-stroke hypertension, whether it's beneficial to aiding the more blood flow to the brain area, and if it's beneficial, no treatment required in it, and consider that cohort is uncontrolled. And if it's pathological, the sudden pressure can produce hemorrhagic transformation or some issues with the secondary stroke, then treatment required to control that blood pressure, and then control is a cohort to identify, to give a more drug to reduce the pressure. So we decided on this basis, a thesis, aim, or hypothesis, that post-stroke hypertension is a beneficial response because body drive itself a response to adding more supply of pressure, oxygen, or nutrients to the affected area. And that's why we aim that the post-stroke hypertension is a beneficial response. And for that reason, we have to induce a stroke. And I'm particularly talking about only the preclinical study. So I designed all the possible clinical scenarios in my animal study, or major clinical scenarios. So the first one is in the method section that we have to induce the stroke. So I done the unilateral middle cerebral artery occlusion model, which is kind of a primary site, or maybe I would say that main side of the having more than 70% of the stroke or ischemic stroke happens around that territory in clinical side. So how I did perform the MCO. So basically I performed two way in my study. So one is implanted the suture from ECA, which is external carotid artery, towards CCA or ICA, which until it blocks the middle cerebral artery. And I also used another technique in my thesis, that I inserted the suture from CCA until it blocks MCA. And I left that occlusion for 2 hours, and then I removed the suture and reperfused the artery, which is exactly what happens in a clinical side when the clot retrieval technique or endovascular clot retrieval technique, which remove the clot and then allow reperfusion into the brain. Right. To record all physiological signals in real time with 24/7, I implanted the 2 telemetry device into the rat to gain the blood pressure, ICP, intracranial pressure, brain tissue oxygen signals 24/7 in the freely moving rat in its cage. And as you can see, BP catheter. So there's dual pressure catheter. So one is a blood pressure and one is ICP one, and this is oxygen, tissue oxygen telemeter. So the blood pressure telemeter, which was inserted into the abdominal aorta to gain all the blood pressure and cardiovascular parameters like heart rate, respiratory rate, and the blood pressure and everything, systolic, diastolic, and mean arterial blood pressure. And then second catheter was tunneled through the subcutaneously to the intracranial pressure to measure the intracranial pressure. So that was inserted, as you can see, in a brain skull, where it was just implanted underneath of skull. Oxygen electrode was also implanted in the penumbra area, stereotaxically, as you can see here. There's a kind of spot, and the other electrodes, which has a reference and auxiliary electrode, which was underneath of skull to remove the noise level. Right, so this is kind of a representation how I implanted all the telemetry device and how animal behaves in its cage. So basically, there's no tether that was outside of the animal or in the cage, which doesn't add any added stress on the animal. An animal is basically in his cage and moving as normal as he can in its cage. As you can see, the telemeter body was implanted into the abdominal aorta. There was 2 telemeters, and that was subcutaneously tunneled through the brain and stereotaxically implanted into the underneath of skull. As you can see, the carbon-based electrode here, which was implanted to gain the tissue oxygen level into the penumbra area. And this is the blue smart pair, which can where we set it up that the animal cage sits on top of it, the smart pair, which can actually chart the wireless telemetry and then keep recording the signal and transmit the signals digitally into the computer. Right, so there's one experimental protocol for one animal. So 14 days before surgery, stroke surgery, I implanted those old telemetry device and then allow animal to recover. Once animal recovered, the 3 days before stroke surgery, I run the behavioral study protocol to gain all the functional outcome or functional baseline. And then on day 0, I performed the middle cerebral artery occlusion surgery and the sham surgery. And then day 1, day 3, day 7, and day 10 post-stroke, I run the again behavioral protocol to gain the functional assessment and followed by the histology. Right, moving towards the results section. So this figure indicates the acute response to the stroke, showing in 60 seconds of average. So this shows exactly what happened during or before, during, and after stroke within that 5 hours of boundary or 5 hours of collection of the data, which 1 minute data of average. So as you can see, the blue shaded area represents the anesthetic period. This is first blue shaded area, which basically induction of anesthetic while I was performing the middle cerebral artery occlusion model or occlusion surgery, and the second shaded area, which presents when I reperfuse the MCA and remove the suture. The first red dotted line presents when I actually exit time point when I induce the stroke, or like means we're blocking the MCA. And the second red dotted line when exactly I remove the suture and allow artery to reperfuse. Right, so the data showed here in form of the mean arterial pressure, heart rate, intracranial pressure, and tissue oxygen level. And as you can see, the graph shows when I actually occlude the MCA, the tissue oxygen level like drop below baseline level, and at the same time the blood pressure tend to rise along with the heart rate. However, didn't see any significant change above baseline level in the intracranial pressure. Right, so I'm moving towards a separate section of the different clinical scenarios, and I'm just recruited. The thesis aim was only based on normotensive rats, which represent the normotensive group. They might also have a stroke in their young or later life. So thesis aim raised the question, is the preventing post-stroke hypertension in normotensive rats detrimental? So for this reason, I recruited all normotensive rats, and the first group was uncontrolled animals. So that means there was no treatment given, and I left as it is when I induced the stroke. So as for example, this is baseline, I induced a stroke here, and the post-stroke hypertensive response may pursue that one after stroke. And then the response, dynamic response, come back to the normal normotensive or pre-stroke baseline level in few days or weeks. And in control group, so as you can see, the nifedipine, I use the nifedipine, which is calcium channel blocker, to keep the blood pressure towards baseline level in the 72 hours of stroke or acute period of stroke, and I denote it as a control group. Now, moving towards all physiological signals, as you can see, these all signals contain or shows as the mean arterial pressure, intracranial pressure, cerebral perfusion pressure, which was kind of an indicator of that indirect indirect gradient of the cerebral blood flow, which was derived from MAP minus ICP, and the tissue oxygen level. And this is a daily average data until the end of the protocol, which is, you can see the day 9. And stroke was induced on day 0, which you can see the vertical black line. So in uncontrolled group, where there was no treatment was given, and as you can see, the blood pressure increase after stroke remained elevated for a few days, while ICP was also elevated, however, with a slower rate compared to the blood pressure. While CPP was calculated from MAP minus ICP, again, I just emphasize here, and then it was increased in a significant level after 48 hours after stroke. Unexpectedly, we found a variability in our tissue oxygen level, which probably due to the anatomical variation within that rat or within that group in the rats. And in control group, so as you remember, that I given a nifedipine, which is calcium channel blocker, to reduce the blood pressure into the acute period of stroke. And the nifedipine has significantly reduced the blood pressure towards baseline level in the 3 days after stroke. Also the ICP, which makes the CPP significantly elevated above the baseline level. And I also noticed the tissue oxygen level was also elevated significantly above baseline during the treatment period, due to the characteristic that the nifedipine has tendency to increase the cerebral blood flow despite reducing the blood pressure. Right, so I run the, as I said, a different behavioral protocol or different behavioral test to check the functional assessment. So I run some of the behavioral tests. So one is a Circadian test and second is a cylinder test, which is kind of a very economical to the left setting, and which gives a direct indication of the sensory motor outcome. So animals were assessed in the functional impairment before day 0, like to check the functional baseline, and on day 1, 3, and 7, and 10 after ischemic stroke. The sticky dot test assessed the sensory motor function, measuring time to remove the final dot, or basically the small adhesive 1 square meter dot. I put it on a 4-po, and when they remove it within 120 seconds, then I record that timing. And the cylinder test measures basically the asymmetry that happens after stroke, and also evaluates the motor outcomes. So animal was kept for particularly in cylinder test in a cylinder for 5 minutes, and for their exploration was recorded, and the pole movement was also recorded and evaluated in terms of the number of rears during the exploration in 5 minutes, and percentage of right pole and left pole in terms of how much they use to touch the inner side of cylinder, which was also evaluated in terms of functional assessment. So this is regarding the behavioral outcome after stroke, and I observed a significant initial impairment in the first few days after stroke. However, all animals recovered towards the baseline at the time progress in all tests. And this is the last slide of the first aim in terms of the infarct volume survival analysis and edema volume measurement, and there was no significant difference between the uncontrolled and control group in these parameters. So in summary of the aim 1, I found the profound and immediate increase in post-stroke hypertension in all rats, however delayed increase in ICP, but the treatment with the nifedipine did not reduce the tissue oxygenation. Probably that's the reason that there was no significant effect in the treatment on outcomes. And that's why we can conclude that the preventing the blood pressure increase after stroke was not detrimental in a normotensive rats. So that was the normotensive rat. Now moving towards thesis aim 2, for this reason, for this aim, I picked the spontaneous hypertensive rat. Basically, that that presents the hypertensive patients in the clinical side. And I raise again the similar kind of question that is preventing post-stroke hypertension in hypertensive rates detrimental. And if we over controlling the post-stroke hypertension down to the normotensive level in the hypertensive rates detrimental. So basically over controlling rates or over controlling group cohorts mimics the undiagnosed hypertension. So as you can see, a similar group to understand uncontrolled, which has a different baseline, as these are hypertensive animals, which has a higher baseline because compared to the normotensive baseline level. And when I induce the stroke, you can see they may have a post-stroke hypertension in uncontrolled group. There was no treatment in this group, sham group, and then control group, which I use the labetalol as a treatment strategy. And then as you can see, when we induce a stroke, I use the labetalol for 72 hours to keep the blood pressure towards a pre-stroke baseline level. And the last group, which was over control or mimicking the undiagnosed hypertensive group, so I use the labetalol quite higher dose to reduce the blood pressure towards normotensive baseline level throughout whole protocol. Right, so that's a kind of a figure shows all SHR has a pre-stroke baseline around 140 millimeter mercury, significantly higher to the normotensive baseline level. And upon the induction of stroke, that produced the post-stroke hypertension also in the hypertensive animals. And when I derive this data from change from the baseline, you can see the magnitude and the time course are kind of similar in the both cohort, normotensive and hypertensive. So it's similar kind of AIM-1 results. So AIM-2, again, the similar physiological all signals, mean arterial pressure, intracranial pressure, CPP, which was derived from MAP minus ICP, and tissue oxygen levels. And this shows the green line, which is uncontrolled group. As you can see, uncontrolled group data shows the post-stroke blood pressure increase along with the ICP and CPP, and tissue oxygenation, however, that was not significant. But compared to the labetalol, reduced the blood pressure towards pre-stroke baseline level, however, increased the ICP, and that's why the CPP was reduced below baseline level. However, the oxygen level was increased during the treatment period of 72 hours. And this is a characteristic again of the labetalol, which has a tendency to increase cerebral blood flow despite the reduction in the blood pressure. And that's the last group of the work control, which is undiagnosed hypertension. So we try to mimic that scenario in the animal study, that if we reduce the blood pressure below baseline level, pre-stroke baseline level, what happens and what are the outcomes we get. So over control group, the blood pressure was reduce the pre-stroke baseline level, that increased the ICP, reduced the CPP. However, we found the big variability in the tissue oxygen level because of higher mortality in this group. So I observed significant initial impairment in the first few days after stroke in all animals, except over control animals has also significant impairment on the ipsilateral side, which is also on the stroke side. So we generally see the impairment on the contralateral side, where how the cross wiring happens in the brain. But we found that animal was significantly impaired in ipsilateral sides too in over control animals. This shows infarct volume and survival analysis. As you can see, the animal in over control group had a significant infarct volume and mortality compared to the uncontrolled group. So in the summary of AIM-2, I found magnitude and time course of post-stroke hypertension kind of similar in hypertensive and normotensive animals, and no difference found in control and uncontrolled SHR or hypertensive rats. Basically, with control was labetalol was given for only 72 hours, while high mortality and infarct volume in over controlled group, where I given a high dose of labetalol to mimic the undiagnosed hypertension. So in conclusion, results suggest that when we're setting the blood pressure target after stroke, treating towards pre-stroke baseline level may not produce a negative outcome, but treating below baseline level may have negative consequences because of hypoperfusion, where clinician may try to treat the blood pressure before true baseline, below true baseline level. Right, so then thesis M3. As you can see, the third aim was totally focused on treated hypertensive patients. And we raised the question that is controlling blood pressure after stroke in treated hypertensive cohort detrimental. As you can see, the treated group, so I actually gave a 28 days treatment with the enalapril for the hypertensive rate to keep the blood pressure towards normotensive level. So that's a 4 weeks of treatment. Then I induced the stroke. I kept the same enalapril treatment to the treated group, but induced the stroke, and we thought maybe produce the post-stroke hypertension response in those cohort as well. And again, I given additional drug treatment with the labetalol in control plus treated group. Labetalol treatment was given for 72 hours, while enalapril was continued over the time, over the experimental protocol. Right, so that shows, as you can see, the mean arterial pressure. The post-stroke hypertension or blood pressure increase on the stroke day, but that was returned to the baseline level within 48 hours in both the group. And while tissue oxygen level was increased in a treated and control group, as I indicated, because of labetalol, because of its characteristic. Now, functional outcome, both groups showed initial deficit after stroke, but they showed recovery pattern close to the protocol. And then there was no significant difference between the histology and survival analysis. However, there was a bit of mortality, but not significant compared to between the groups. So in summary, I found the brain tissue oxygen was maintained above the baseline in treated and control. However, there was no difference between, no difference was calculated between the infarct size mortality. So no consistent evidence to suggest that preventing post-stroke hypertension in subjects already on antihypertensive medication, which may not produce a negative outcome. So that was my thesis conclusion. So novel thesis conclusion is basically the blood pressure increased immediately after onset of stroke, and there was similar magnitude and time course regardless there was different pre-stroke baseline level, either hypertensive or normotensive, and preventing blood pressure from increasing after stroke did not produce the negative outcomes, except if we try to reduce the blood pressure below their pre-stroke baseline level. And what's kind of relevant and significant to the clinical side, that my thesis highlights undiagnosed or poorly controlled hypertensive group, as they present in the many stroke patients, likely increase the chance of mortality and possibly failure of so many clinical trials due to not looking at zoomly or focusedly on this cohort. And the middle ground approach for the treatment may be necessary to protect the perfusion pressure to the brain in the acute phase of stroke, particularly to prevent the secondary stroke outcomes. So in summary, I suggest that while preventing the blood pressure from increasing after stroke do not produce the negative outcomes, but controlling blood pressure towards normotensive level or below pre-stroke baseline level produce the detrimental outcome. So that was my doctoral data, and in my current research in my postdoc, that I'm pleased to contribute that my PhD data contributes into the master stroke trial, which is ongoing trial in the Auckland District Health Board and other part of New Zealand Hospital at the moment, which is ongoing at the moment. So which was pleased to see. Second, I'm involved with the project which is happening in the preclinical side and clinical side, that to using the different anesthetics which may produce a different effect on the stroke outcomes in the patients, either in the functional side or also on a disability side. And also, if we, because the anesthetic, because the patient has to go to the general anesthesia while the clot retrieval technique is happening with the in the clinical theater. So if we increase the blood pressure during the general anesthesia, because the general anesthesia may reduce the blood pressure. So if we increase the blood pressure at certain level under the general anesthesia, may produce different outcomes. So we are trying to look at that one as well. And the third project I'm involved in, which trying to look at the carotid body's involvement. So carotid body is basically the bunch of chemoreceptors located into the bifurcation of the common carotid artery, and that carotid body involvement in the brain-gut axis in a metabolic homeostasis. So we just recently published an article in a Circulation Research and last month, which I'm also part of and involved in this project. So thank you so much, everyone, for listening my talk, and I would like to acknowledge and thanks to all my supervisors, mentors, and lab members, and also funding bodies and university for continuous support and help during my research and ongoing projects. I'm happy to have any questions at the moment. Thank you.
Thank you, Pratik. Pratik, did you do a control group of hypertensive animals that you lowered the blood pressure to normal tension without the stroke and then ran your parameters for function?
Right, there is a good question. I haven't run that one. That would provide a good control, actually, which is very good suggestion. I'll go back and have a look whether any literature might have that produced or have done it. Possibly not, but I think we certainly have interesting to do that to just match the control, whether what kind of
you actually
response they
have
have.
two interventions, the stroke or the ischemia and the blood pressure control, and separating out the effects of each would be important. How did you deliver the drugs which controlled the blood pressure for the days after the stroke?
That's a very good question. Actually, we use osmotic pump to deliver the drug because we at the beginning of my PhD, we were planned to give IP or IV, but that was not feasible to give amount of the stress because for IV, I have to maintain and train the animal to be in a perfect box to inject the drug from the IV line from that we generally do to the femoral artery. But then generally what happens, then IV line generally block, and we have to consistently flush them to not to get blocked. And if that blocks, then I think whole things is vanished or messed up. So we generally we optimize the dose and everything with the levodopa in the osmotic pump delivery, which we found was quite, which when we implant this osmotic pump during or when we do the stroke surgery, it was consistently releasing the drug depends on osmotic pressure and subcutaneously. Yeah.
And the idea there is to make sure that your therapy delivery device doesn't interfere with the physiology itself. So that's
True.
very good.
Yeah.
Very good. Other questions for our speaker, please?
Hi, Pratik. That sounds like a very translational idea you are running.
Yeah.
But I have a couple of questions. The first thing is hypertension is also depends on the sex as well as the age. So you tested only males or both females and males? And also, what is the age group of your animals? Are there you tested anytime any older animals because they're more prone to hypertension, right?
That's very good question. So what we have used the Hypotenuse Universe is like neurogenic hypertension model of spontaneous hypertensive rats. So generally, I use that age of around 24 weeks of animal age, and that I kept the similar age between the cohort non-hypertensive hypertensive animals. Now another question is, I use only male for this study. We had a plan and we have a plan that ongoing with the use the female, but we have to look out and we have to optimize the protocol that depends on their cycles too. So which time is the right time to induce the stroke and everything. So we're working on it. Another thing is age-wise. So 24 weeks is a kind of very young age, relatively young age, and young age generally the 15% of the total stroke also produce and also happen in a young age. And the STAIR guidelines suggest that if you're trying to achieve certain goals in terms of the higher age population, you have to start with the positive control to do the younger age, and then you can move towards older age. So that's first thing. And second thing is the 24 weeks of age where hypertensive animals have a sustained high blood pressure. So generally that plateau and the sustainability or sustained blood pressure achieved in a 12 to 14 weeks of hypertensive animals, which is neurogenic blood pressure and genetic model of the hypertension. So that's why we use the hypertensive rats which have a sustained hypertension during that time.
Yeah, wonderful. My second question is, hypertension is also dependent on circadian cycle. So, because humans are diurnal and rodents are nocturnal, so you consider that, or tested whether, because people say that whether hypertension is in hypertensive patients, it depends on whether it's the daytime or the nighttime. There will be changes, and so
That's very great question. Some of the stroke also happen in a sleep, and
right.
also daytime, and daytime also. There are different variability and the cases. Another thing is daytime the human's blood pressure is high compared to the sleep time, because the sleep time that there is no supine position in sleep time, and that difference with the gravitational force and everything. So and also depends on the circadian rhythm. That's true. So we try to match, and we as you know, like how we work in animals, so that we have different day cycle and night cycles too, and we perform particularly this project in a day cycle, where generally most of the also human patient also have a more tendency to have a having a stroke in the daytime.
But animals are nocturnal, right? Like rats are, like we are saying that humans are
More active
diurnal,
in
and but you are saying that you are inducing strokes in rats during daytime. That is the reverse. Well, anyway, you can think
active
about it
cycle.
later. But
Yes,
I will let others ask any other questions if anyone has
sure.
anything. Thank you.
Yeah, thank you.
Hi, Pratik. Very nice talk. I was wondering if you look at what's the effect of your drug on any of the non-molecular pathways.
Which pathway? Sorry.
Any molecular pathways? Did you look at any inflammatory or any other engineering pathway was affected by your drug?
That's a great question.
Change the outcome?
Yeah, that's a great question. I didn't look at any molecular pathways. We certainly are planning to do further to go only on a molecular pathways, because we would like to go to the base of this post-stroke hypertension response. But we actually try to understand first the core physiology of the whole physiological mechanism, what's happening, what time is the blood pressure increasing, what time is ICP increasing, what's the tissue oxygen level. So we try to first understand the core physiology and physiological signals, what happens with the onset of stroke. But we haven't looked at any molecular pathology when the any drug effect on those kind of scenarios in the brain. We certainly would like to do it.
Okay, thanks.
Hey Pratik, interesting findings, really great work. I have two questions for you. In your aim one, instead of employing all or none kind of strategy, what if you employ a graded control strategy? Like if you control the post-stroke hypertension by 50% or 25% instead of completely restoring it to baseline. So what would be the outcome, do you think?
That's a great question. I think a literature, I found one of the studies that they have tried to look at, I think, to reduce at certain level. However, they did not produce any negative outcome, first thing. Second thing, I wanted to look at that what happens we completely achieve the pre-stroke baseline level, because we thought that that response may be a beneficial response, maybe a detrimental response. So if we achieve just only the pre-stroke baseline level, then what happens? Some of the study also have done it at the proportional reduction of the blood pressure. However, they did not produce any conclusive evidence. So that's why we didn't go for the proportional or gradient changes or gradient dose of the drug to decrease the blood pressure from the initial control animals. Yeah.
Okay, interesting. Yeah, thanks. The second question is that acute post-injury hypertension is also common after intracerebral hemorrhage. So, can you reflect on what would be the outcome after controlling hypertension, and if you subject those mice to ICH? Just wondering, like how it would affect different disease model.
Yeah, I didn't look at that direction, but I would suggest, because not suggest, but what I have seen in my study as the increase in blood pressure, which goes around, even rats to and even human to the 220 millimeter mercury systolic after having a stroke within acute period of stroke. So 220 millimeter mercury, which is significant high level and maybe a problematic level. So if we do not achieve the right pressure, then that will produce a hemorrhagic stroke, and that was in some of the animal that produced the hemorrhagic transformation, and there was a hemorrhage in my animal, some of the animals. And then literature does say that 6 to 9% of the stroke patient produced a secondary hemorrhagic transformation. So I'm not addressing your question, but what I would say that ischemic stroke can produce hemorrhagic transformation, but I can't suggest or I can't direct any particular comment that whether hemorrhagic stroke has any particular event in a hypertensive scenario if having a ischemic stroke.
Okay, gotcha. Thanks.
Thanks, Dr. Pratik. Thanks for joining so early in the morning New Zealand time. And so we all enjoyed your talk. And yeah, it's quite good. And thank you again. Yeah.
Thank you very much. It's a great kindness for you to come on at this hour. Appreciate it. Take care now.
No problem. Thank you so much, everyone, for time. Cheers.
Yeah. Good luck in your research. Yeah. Bye-bye.